Well, thank you very much. I should start off by saying what a pleasure it is for me to be with you here in Mumbai. I gather that, and I had forgotten that in December you had a meeting where you beamed me all the way from London, and I was able to talk to you at that time. For me, it is much nicer to be here with you in Mumbai. The weather currently in Mumbai is appreciably better than it is in London. So thank you for making it possible for me to be with you. You've just heard and you've just seen a beautiful demonstration of the normal heart. As Dr. Snehal has told you, we're now moving from the normal heart, where everything is straightforward, shown to you beautifully by Dr. Deshpande, and we are talking about the most complex combination of cardiac lesions, as Dr. Snehal has also intimated to you. In the past, that has been controversial. She's asking me if I can clarify the whole situation for you. I think I can, but again, for some of you, this may come as a bit of a surprise because Dr. Snehal trained with Dr. Richard van Praag. Many of you, well, not many of you in fact, because most of you were not even here at the time I last visited Mumbai, which is in 1984. But in 1984, Dr. van Praag and I were together at KM, where we had an intense discussion of whether isomerism existed. And at the time, Dr. van Praag was trying to tell everybody there was no such thing as isomerism. So what I'm hoping to do over the next 25 minutes or so is to persuade you that that is incorrect. But we have to start with a question, as you see on the screen at the moment: does isomerism exist? So let me take you into the situation where you have to decide whether or not there is such a thing as cardiac isomerism. So the patient is in front of you. You find the heart is in the right chest. Already you're worried that something funny is going on. You look below the diaphragm because you all are taking note of the entire patient, and you find there is a midline liver. The stomach bubble is to the right. What are you thinking about? Now, all depends how you approach this situation. You need to know already, when you've seen these unusual findings, the likely diagnosis. And then, most importantly, you need to know how to describe it. So how do we proceed? It depends on your specialty. If you are a pediatrician, and primarily you are concerned with what's going on in the whole body, your first thought will be, is there a spleen? Are these combinations going to impact the influence of infection? If it is a neonate and you find these things, you're going to be particularly worried to know whether or not the intestines are malrotated. Now, I think here most of you are also cardiologists, pediatric cardiologists. So, of course, you're interested in all those things because as pediatric cardiologists, you don't ignore what is going on throughout the body, but you want to know, do those findings suggest to you likely intracardiac lesions? And that is going to impact on the way you begin your investigation of this neonate, perhaps. Here in Mumbai, probably you will see older children with these combinations. How should you approach the heart, and how should I describe it? Now, if you are as old as I am, and there are very few of you who are in this room who are as old as I am, you might call it the Isomerc syndrome, because it was Isomerc, the Scandinavian pediatrician, who first focused the attention on one side of these entities. And because Ivermark was a paediatrician, he concentrated very much upon the spleen, and in fact his paper talks about abnormalities of the spleen. So when I started in the field, which was the early 1970s, we'd gone away from calling this the Ivermark syndrome, and in fact, the popular term at the time was splenic syndromes. But in the 1970s, we also had a significant influence from Dr. Van Praag and from Dr. Van Meerop. And they suggested that these funny arrangements, which were neither the normal arrangement nor its mirror imagery, were giving ambiguity in the eyes of the observer. So they produced this term, situs ambiguous. I'm going to show you eventually why this is inappropriate, because in reality there is nothing ambiguous about these patients. But if you currently work in North America, and many of you did your training in North America, and you will have been influenced by the North American approach to things, they call this situation heterotaxy. And I think that that is arguably one of the worst terms ever invented by man. So what I would like to try to do is to persuade you that the approach to these specific patients requires an understanding of isomerism. Now, all down the screen at the moment, you see question marks. So let's approach each of these in turn. You all have heard from what Dr. Snehal has already told you and from what Dr. Deshpande presented to you this morning. I am very fixated that we should use words in such a way that everybody understands them. And I think that means we should use words like the man in the street uses them. So we shouldn't be creating little coteries amongst ourselves so that we know what we're talking about, but nobody else knows what we're talking about. That is a recipe for disaster. So let's look at how these things are defined. What is heterotaxy? There is a very nice paper that is written by Dr. Kim, as you see, 2011, where he analyzed the background to these entities. And he gives the definition here for heterotaxy by the nomenclature working group. Now, I am a member of the nomenclature working group, and it so happens I don't agree with this definition, because the nomenclature working group have decided that heterotaxy is the same as visceral heterotaxy and an abnormality when the internal thoraco-abdominal organs demonstrate an abnormal arrangement across the left-right axis of the body. Now, that's not a particularly good definition, but what the nomenclature working group is trying to define is the situation that we can now see using computed tomography. I'm going to be talking quite some time later in the day about the advantages of computed tomography, because to me, as a morphologist, computed tomography shows you the anatomy better than anything else. And I've been fortunate to work with this young man who is a cardiologist in Kobe called Shumpei Mori, and his images are spectacular. So you see that these are the lungs that he has segmented, and he is showing them to you. And the right lung has 3 lobes. The left lung has 3 lobes. And there is a space in the right lung rather than left lung where we find the heart. So this is the sort of thing you might see in the patient I intimated from the outset. Another of Dr. Mori's patients on the right lung has only 2 lobes, and on the left lung has only 2 lobes. And in this particular patient, when we look below the diaphragm, we see there are multiple spleens. We go back to the first patient who I showed you with right-sided heart, and that patient has a midline liver. So everything that I've spoken to you about in my opening sentences can now readily be seen using computed tomography. And that tells us that in so-called heterotaxy, everything doesn't go into one big basket, but rather we can find two subsets of patients. In fact, we'd known that from the outset when we talked about the splenic syndromes. We called them asplenia and polysplenia. But that's not necessarily the best way to divide them. So how is it best to segregate and describe them? And this, I believe, is where the ability to image now these various organ systems, as shown by Dr. Mori, comes into its own. Because what I have already shown you is the presence within these patients of isomerism. So I'm back now at Dr. Kim's rather nice paper, and he gives you an excellent definition of isomerism. I won't read all that out to you. You can read it for yourself. We're not going to have a karaoke session. I'll let you take what is important from the information that is on the screen, and instead I'll show you a picture, because pictures are worth thousands of words. And those are two structures that are isomers, because isomers are mirror images of each other. And when they exist within the patient, then we can say the patient has isomerism. Why do I know this is isomerism? Because the fount of all knowledge now is Wikipedia. And there you see the Wikipedia definition of what is on the screen. In fact, we are talking about enantioisomerism, which is very hard to say. So it's much easier simply to say isomerism. Now, in fact, you should all know about isomerism because everybody has within themselves the evidence of isomerism. So you will all recognize, I hope, that that is the dorsal surface of my own left hand. And that is the dorsal surface of my own right hand. And you will immediately recognize that they are mirror images of each other. So all you have to do to understand isomerism is to look at your hands. Because in all of us, the parietal structures, the limb myocardial muscles, the leg muscles, the trunk muscles, are isomers of each other. So when we think about isomerism, and we try to understand isomerism, we should remember that the hands are the exemplars of what is bodily isomerism. So does it exist in the setting of so-called heterotaxy? Well, let's take the easy bit first. Let's look at the bronchial arrangement, and we go back to Dr. Mori's exquisite computed tomograms. So this is a normal patient, and as you see, not only has Dr. Mori reconstructed the bronchial tree and the trachea, he's also reconstructed the branches of the pulmonary trunk. And what he shows you is that the right bronchus is short, and it gives off its first branch before it is crossed by the artery supplying the middle lobe of the right lung. The left bronchus is long, and its first branch is given off after it has been supplied by the artery supplying the lower lobe of the left lung. So the morphologically right bronchus is short and eparterial. The morphologically left bronchus is long and is hyparterial. So here is another of Dr. Mori's patients. And now you can readily see that it is the right-sided bronchus that is long and also is hyparterial. And that tells us that this patient's morphologically left side is on the right side of their body. And then when we look at the other side, the patient's left side has a short bronchus, which is eparterial. This patient has everything that is mirror imaged, including the location of the heart with the apex pointing to the right. Now we come back to my desire to talk English rather than Latin, because I am sure that most of you, including Dr. Snehal, would rather call this situs inversus. But if I take this bottle of water, and it has the top on at the moment, but if I took the top off that bottle of water and I inverted it, then all the water would run out, because to the man in the street, inversus is upside downness. Is this patient upside down? The patient is mirror imaged. The adult cardiologists show you situs inversus all the time when they put their echocardiograms upside down. But fortunately, Dr. Deshpande showed us the four-chambered view, as you should see it, with the apex pointing down. So this that you see on the screen at the moment, I believe, is best considered mirror imagery, but mirror imagery of everything in the same patient. But we haven't finished. Here is another of Dr. Murray's patients, and this time again the heart is pointing to the right, but this time we do not have mirror imagery, because both of the bronchuses are short and both of the bronchuses are eparterial. The patient has right bronchial isomerism. The right side of his chest is the mirror image of the left side in the same individual. And here is another of Dr. Murray's patients, with both of the bronchuses being long, both being hyparterial, left bronchial isomerism. So the evidence now is before your eyes. Computed tomography shows you with clarity what is going on. And so, for sure, we can divide the bronchial arrangement into the usual arrangement, the mirror-imaged arrangement, right isomerism, and left isomerism. Everybody comfortable with that? So, what about the heart? Can the heart exhibit isomerism? Dr. Deshpande also told you that for some of my talks I've been talking about cardiac development. So let's look at the way the heart develops. And we know that the things that produce these differences between the right side of the body, the left side of the body, involve the laterality genes. Dr. Snehals also asked me in my next talk to discuss with you whether transposition is a laterality defect. So it's important at this stage that we discuss the laterality genes. And there are two specific genes I'd like you to think about, and the one is PITX2C, and the other one is LEFT1. And PITX2C is the gene responsible for making everything left. But in the developing heart, there is this second gene, LEFT1, that together with nodal stops PITX2 getting to the right side of the body. So the default option for the developing body is leftness, but if LEFT1 and nodal are behaving properly, they stop the default option reaching the right side. So if PITX2 produces leftness and we knock out PITX2, so there is nothing giving us the default option, what will we have? Both sides of the embryo will be morphologically right. Yes? All happy with that? And the molecular biologists, the developmental biologists now can do the most amazing things. So they can knock out these individual genes And that is what you see with the scanning electron micrograph when you look at the undersurface of the atrial component of the heart from a mouse in which we have knocked out PITX2. And I hope you will agree that what you see to your left hand is the mirror image of what you see to your right hand. Yes? All happy with that? What I am showing you there is bilateral morphologically right appendages. The mouse has isomerism of the morphologically right appendages. This is a mouse in which an excellent Japanese developmental biologist called Professor Mano has knocked out lefty 1. Now, there is no barrier. PITX2 can get to the other side. PITX2 produces morphological leftness. And now, I hope you will agree, both the appendages are morphologically left. All comfortable with that? The developmental biologists for sure have shown that the heart can exhibit isomerism. But you all know that in the normal way of human genetics, we do not lose complete genes. We cannot knock out, in the human situation, a gene. So although we can see isomerism in the mouse heart, and I think the evidence shows you that for sure isomerism exists, can we see it in the postnatal heart? That has been the big bone of contention. But fortunately, it is the atrial chambers that show the features of isomerism, as we've seen in that mouse heart. So how do we distinguish leftness and rightness in the atrial chambers? Well, in fact, Dr. Deshpande has already shown you that in the wonderful demonstration she gave you, and she has told you about the morphological method, although she didn't call it that. So what is the morphological method? The morphological method says that when we are analyzing the heart, we should identify structures on the basis of their most constant part and not on other features that are variable. And who was the person who identified the morphologic method? It was no more than Richard van Praagh himself. And he did that in criticism of one of our own papers, and he was 100% correct. And so, like a good student, I took absolute note of what Dr. van Praagh told me, and I've tried to do that ever since. So if we look at the atrial chambers, it is the appendage that is most constant. The coronary sinus is important, as Dr. Snehal told you, but the coronary sinus itself can be variable. So that's why, in the final analysis, we use the appendage. So can we distinguish rightness or leftness on the basis of the morphology of the appendages? So here is the right-sided atrial chamber from a heart from a patient such as I told you about initially. And as Dr. Deshpande has told you, I like now to think of this as the map of India upside down. And there is the other side of this patient's heart, and lo and behold, there is a mirror image of the map of India upside down. Isomeric right appendages. So we showed that a long time ago before Dr. van Praagh had our discussion here in Mumbai, and Dr. van Praagh was not persuaded by that because he said shape can be altered by abnormal hemodynamics. And again, he is 100% correct. So we tried to find a means of distinguishing the appendages that did not only determine on shape. And a young Japanese worker from Osaka came and worked with me in the Brompton Hospital in the 1990s, and he made this observation. You're looking down now on the atrioventricular junctions from the atrial aspect. This is the tricuspid junction, this is the mitral junction. And Dr. Uemura pointed out that on the morphologically right side, the pectinate muscles go all the way around the junction and reach the crux. Dr. Deshpande showed you what the crux is. On the other side, the pectinate muscles are confined within the appendage. And then we also now know that here, within the morphologically left junction, we will find the coronary sinus. So Uemura looked at a large number of patients with so-called heterotaxy, and on the basis of the extent of the pectinate muscles, he tried to distinguish whether both of the appendages were morphologically right, in green, both of the appendages were morphologically left, in yellow, or whether there was ambiguity, as Dr. Van Praag, Dr. Van Meerop were trying to tell us. And as you see, when taking the extent of the pectinate muscles, Dr. Uemura was able, in each of those 182 hearts, to distinguish right versus left isomerism. We've now done a further study where we've analyzed another 240 hearts from patients from archives in the United States of America, and again, in all cases, we are able to distinguish according to the pectinate muscles. So Dr. Snehal says, can I help you in your initial analysis of these patients? And the answer now is yes, I can for sure. Segmental analysis was the system that brought order to the analysis of the congenitally malformed heart. And we all owe Dr. Van Praag a huge piece of credit for focusing our attention on the segmental method. And the starting point of the segmental method is atrial arrangement. And now I can tell you with certainty that when we take the extent of the pectinate muscles, all patients fall into one of four groups. The usual group, the mirror-imaged variant, right isomerism, and left isomerism. There is no ambiguity when we analyze this on the basis of the pectinate muscles. But it is only the appendages that are truly isomeric. So how do they correlate with the other organs? With the bronchial tree, the correlation is excellent. With the spleen, it is good, but it is far from perfect. So when I tell you there is isomerism within the heart, on the base of the extent of the pectinate muscles, that is true. But what is isomeric? It is only the appendages. And Dr. Van Praag was criticizing us in 1984 when we had the debate here in Mumbai, because at that time we were talking about atrial isomerism. And Dr. Van Praag said, if I have a patient with left atrial isomerism, I expect to find 8 pulmonary veins. So again, he was correct, and we should not have been speaking about atrial isomerism. And now you will never hear me say atrial isomerism. I will either say isomerism, or I will say isomerism of the atrial appendages. Because if I'm going to give you the full picture, and that's what Dr. Snehal has asked me to do, give you the full picture, we have to describe all the variables. So what are those variables? The veno-atrial connections. This, in fact, is the most significant variable in patients who have isomeric appendages. AV junctional morphology, ventricular morphology, and so on. We have to undertake full segmental analysis so as to clarify the situation. So the veno-atrial connections are certainly going to be unusual, but if we describe them, we remove the ambiguity. In some instances, they can give you quasi-normal or quasi-mirror-imaged drainage, but in the setting of isomeric appendages. And in fact, It is the arrangement of these veno-atrial connections that can now guide you to the type of isomerism. So when we have right isomerism, we expect bilateral caval veins, but always there will be absence of the coronary sinus, and that is why Dr. Snehal is so correct when she focuses on the coronary sinus. And because the coronary sinus is absent, the veins will go directly to the atrial chambers. Always, in right isomerism, there will be totally anomalous pulmonary venous connection. But in half the cases, the pulmonary veins will come back to the heart, but they will come back anomalously. And in the other half, they will go to the systemic veins. When they come back to the heart, rarely do they go directly to the right atrial roof, more usually to a midline confluence. And then we can distinguish those patterns from left isomerism. Again, we have bilateral caval veins, but in left isomerism, most usually one of those caval veins will go through the coronary sinus. And again, that's why attention on the coronary sinus is so important. But sometimes in left isomerism, both caval veins can drain directly to the roof, and then once more, the coronary veins will drain directly. The pulmonary veins are often symmetrical because you have a left appendage on both sides. They're trying to be morphologically left. We expect interruption of the inferior caval vein because the inferior caval vein is a morphologically right structure, but it's not always present. So we won't be surprised if the inferior caval vein does come to the heart. But when it's absent, the hepatic veins will usually drain directly, but they can also drain through a confluence. So now you have the clues that are going to help you identify what is going on. So let me now answer the first question I asked you. Is there such a thing as situs ambiguous? Is there uncertainty? Is there ambiguity? Only if the ambiguity is in your own mind. Because if you describe each system of organs, you remove the ambiguity. I've already shown you. The bronchuses can either be usual, mirror imaged, or show right and left isomerism. Splenic morphology is now shown with certainty using computed tomography. You can see it with ultrasound. So you know the spleen can be solitary, it can be multiple, or it can be absent. And you can describe that. One of the questions I asked you, is there intestinal malrotation? You need to ask that question and you need to answer it yes or no. But if we come back to the heart, there are only 4 arrangements for the atrial appendages. They match the arrangements that you find in the bronchial tree, but the arrangements are not always in harmony. That doesn't mean we throw the baby out with the bathwater. We don't say that because in a minority of cases there is disharmony that the system doesn't work. On the contrary, it is in those cases where we have disharmony that it is most important to describe each set of organs. So let's come back and let's ask the initial question. Is there such a thing as heterotaxy? Yes, there is. But heterotaxy is anything that is other than the normal. So heterotaxy includes mirror imagery. The thing that the North Americans call heterotaxy is easy because that is simply right and left isomerism. So does isomerism exist? For sure it does. If we divide it into its right and left subsets, then we have the clarity that Dr. Snehal was asking me for in the first instance.
Thank you, Professor Anderson, a lot, and I expect any queries and questions from the audience. Yes.
So, as an echocardiographer, one of the parameters that we look at to decide the visceral situs, whether it is solidus or inversus, is imaging the infravena cava and the aorta at the level of that. So, what is your viewpoint on this?
Again, that is a very useful system. And so you look for the question was, the echocardiographers have been, and I know some of you